Okay, so hi everyone. Welcome to our workshop, which will be discussing international consensus on treatment of high-risk substance use and increased risk of overdose among youth. So as I said, as you enter the room or maybe type in the chat where you're from, what your background is, it gives us an idea of what the attendance looks like today. Maybe that will help us with the discussion and where we want to take it later on. So I've no actual or potential conflicts of interest in relation to this presentation. So this is just a quick disclosure slide. And I am happy to be joined today by Dr. Ignaszewski, who is in the audience. She's a psychiatrist at BC Children's and at the Vancouver General Hospital, and she specializes in addiction psychiatry, child adolescent psychiatry, and adult psychiatry. Martha is there with her video on, please feel free to ask any questions you have for her at the end of the presentation. And a bit about me as well. I did my undergrad at McGill, and I'm now a master's student at the University of British Columbia. So my supervisor is Dr. Michael Kraus, and I focus on, my research focuses on addiction and concurrent disorders, particularly among youth. So that's a bit about me. So the overview for today's presentation, it's going to be subdivided into 4 sections. I want to give a quick introduction to high-risk substance use and overdose among youth. I then want to talk about the consensus statement, how it was developed, going over the Delphi process, what the timeline looked like for the project, and give a brief description of the panel of experts that we had involved. And then we'll go over the main findings, so what the general consensus statements was among the experts, and then we'll open the floor to discussion and feedback. So my presentation shouldn't take too long, should be about 20 minutes or so. And so you feel free to ask any questions in the chat as I go, but I'll take a look at them after. And Martha can also let me know if there are any that are like pressing, or if anything big, anything happens to make sure to stop me. And just to mention that the term youth, I'll be using it throughout today's presentation. I just use it to signify anyone below the age of 25 years old. So the objectives for this workshop today, there are a few things that I think I would like you to take home, or some questions that throughout the presentation I'd like you to think about. So what does the situation currently look like for youth in BC and in North America generally? What can we do to rectify the system of care for youth? And what do experts in the field agree or disagree on that needs to happen with regards to the system of care for youth? And then what's next? So what are the next steps in order to take this agreement or disagreement and really ameliorate the system of care? So I would like to start with this slide because it really shows the importance of the overdose crisis right now in North America. So despite medical advances in other aspects of life, the opioid overdose crisis has offset nearly all gains in life expectancy from other causes. So the life expectancy at birth in Canada did not increase from 2016 to 2017, and this is largely attributable to opioid overdose crisis, the opioid overdose crisis, particularly among young adult men. So here we see this bar is the light blue is males, dark blue is females between 20 and 24 years old. We see a decrease in life expectancy, and this happens from the young age of even 15 all the way up to 45. And the opioid overdose crisis is threatening the life expectancy of a generation of Canadians and Americans. And in BC, individuals under the age of 30 represent 20% of all overdose deaths. And in the United States, in a single year alone, almost 5,000 youth died of overdose. If those aren't surprising enough, this is the last 5 years, the leading cause of death among youth in Canada. And for the last 5 years, accidental and unintentional injuries, which include overdoses and motor vehicle accidents, have been the leading cause of death for youth in Canada, pretty unanimously. So the second leading cause is suicide, and then all other causes are in gray. So this is all other causes of death in Canada. A similar situation can be seen in the United States this is a single year in 2019. Unintentional injury, which again includes motor vehicle accidents and overdose, are the majority, as the leading cause of death in the United States. Suicide, again, second with 23%, but really almost half of all deaths among youth in the US in a single year were related to unintentional injury. Now, I mentioned that unintentional injury includes motor vehicle accidents and overdose. And what is that ratio? Well, this is in the United States in that same year. It's roughly 50% is motor vehicle accidents, and almost 40% are poisonings or overdoses. So overdoses are definitely the second among unintentional injury deaths, but this is a changing trend. This is a single year. If we look at it over the last 10 years or 20 years from the start of the century, motor vehicle accidents in orange are decreasing, whereas overdose deaths are increasing. And these trends are due to several factors, like changes in roadway design and campaigns to reduce drunk driving have really helped decrease motor vehicle crashes, which is fantastic. On the other hand, drug overdose deaths are skyrocketing across North America. And this is in large part due to increasingly toxic drug supply and a current system of care that is ineffective at addressing the complex and multifaceted needs of youth. So that just really paints a really grim picture with regards to drug overdose deaths and substance use related harms. And this is an international challenge. So for youth with high-risk substance use, behavioral interventions and abstinence-based treatments are commonly used for youth. And so in a cohort study by research done in Boston by Alinsky and her colleagues, they found that less than 1/3 of youth received addiction treatment 30 days after an overdose, and less than 2% received pharmacotherapy. So less than 2% of youth 30 days after overdosing were provided pharmacotherapy, which is really shocking given that pharmacotherapy is the gold standard for adults with opiate use disorder. So to reiterate, less than 2% of youth were given pharmacotherapy, which is the gold standard for adults. And so many questions can be raised about that, and much of the question as to why. And so this is these findings reinforced by a narrative review that we did with our team. And this was done to identify the existing evidence on treatment approaches for youth with high-risk opiate use. And so this narrative review, we found similar, extremely limited research and an unexisting system of care and a huge gap in the literature. But the main finding from the literature that was published was that there is no evidence to deny youth with opiate use disorder or high-risk opiate use the same treatment options available to adults. So given this background and given these findings and the figures that I presented, we sought to design a Delphi study. And the reason for that is that there's a lack of good clinical guidance for youth. And so good clinical guidelines or recommendations could provide explicit recommendations for clinicians who are uncertain about how to proceed, maybe overturn beliefs of doctors that are unaccustomed or accustomed to outdated practices, and just generally improve the consistency of care for individuals below the age of 25. And so the objective of this Delphi study was two parts. We want to first source best practices from international panel of experts, and we want to establish a consensus for the screening, treatment, and management of high-risk substance use in adolescence and early adulthood. So for this Delphi study, we had a panel of experts, and this panel of experts was a group of 31 experts who are internationally renowned and are distinguished clinicians or researchers in the field of youth substance use disorder and are able to provide insight for their in-depth direct experience in working with adolescents. So the table on the right shows the representation. So coming from 10 different countries, most of them were psychiatrists. Most of the psychiatrists are also duly specialized in child and adolescent psychiatry and addiction psychiatry, just like Dr. Iggy, who's on the panel with us today. And so that gives a good representation of the panel, including experts from North America and Europe, and also New Zealand and Australia. And so what is a Delphi? So how does this work generally? This is a brief overview of what a Delphi looks like. So it includes a first step is the semi-structured questionnaire. And with that questionnaire, we're looking to create statements or create a discussion among the experts. This discussion is then taken into a round of rating. And so once statements are made, so once the semi-structured questionnaire is answered by the respondents, statements are created. These statements are sent around to the panelists, and the panelists will agree or disagree. So if they agree and most of them agree, it will reach a consensus. And so that will be put aside for the final consensus. If they disagree upon it, then they can suggest a new phrasing or suggest an entirely new statement. And those new statements or the different phrasing will go into a second round of rating, and then finally a third round of rating, every time removing whatever consensus statement was reached for the final consensus statement. So I'll go over what happened for our project in a bit more depth, but I want to give it a quick overview so you get an idea of what was actually happening. So these are the details for our consensus statement. So based on the literature review that I already mentioned, we created a semi-structured questionnaire. And it included 40 questions. The 40 questions were presented, and the entire project and the ideas and concepts were presented in an international workshop earlier in the year. And this workshop had roughly 80 attendees, and it was an opportunity to comment and provide feedback, as well as discuss the content and impact of this research, looking with external feedback. So given any external feedback and with this questionnaire, we sent that to the panelists, which were able to respond and create initial statements. Based on those statements, we sent that around. So we created 63 initial statements, and these were sent to all of the experts, so to the 31 experts that we had on the panel. And from the statements, 28 of them reached consensus. So 28 of the statements were agreed upon unanimously by all of the experts. 32 of them were actually rephrased and sent around for a second round of rating. In the second round of rating, the same process happened. So we asked the panelists to rate these statements on a scale from 1 to 5, whether or not they agreed with it. And when the second round, 16 statements were agreed upon, and 15 were, and the rest were presented, the rest were presented in a webinar that included all of the experts. So at this point, after 2 rounds of rating, we wanted to bring together all of the experts to really discuss the statements that didn't reach consensus yet. They were seen as controversial, and we thought it would be better to have everyone in a workshop and to discuss it over Zoom. So that's what we did. And then we came out with 20 statements for a third round of rating. And in this third round, 16 statements reached consensus. So given these details, we have a first round with 28 statements, a second round with 16, and a third round with another 16. All put together, we end up with 16 total statements that reach consensus from an international group of experts on the treatment and prevention and management of high-risk substance use among youth. So it's a very, very important document. And so in the next coming slides, I will summarize what these 60 statements mention, and also reflect what the discussion was among the experts in the panel. And I'll do so in five different sections. So each step of the Delphi study, so every step of the ratings or of the semi-structured questionnaire, was divided into 5 domains. So the 5 domains are listed on the slide right now. It's outlining clinical risk, determining target populations, defining intervention goals, exploring experiences with evidence-based interventions, and identifying appropriate treatment settings and expertise. So these 5 domains were in every single step of the way, and we had statements and questions for every single one. So now I'm going to go through 1 to 5 and really summarize the discussions that were had within the experts and these statements that were shared. So to start with the first one, outlining clinical risk. So the goal of this domain was to outline the clinical risk of substance use and the development of substance use disorder in youth. A summary statement, or an important statement that was brought up within the experts, was the following. So screening for mental health problems, substance use problems, and related risk is recommended for all youth. There are also other statements like youth who are known to be at risk for substance use disorder due to mental health problems or family history of substance use disorder or mental health problems should receive targeted prevention efforts and more frequent screening. So this was a pretty loaded statement. And it definitely was an area of contention. So I'll bring this up in the next couple of slides. But it's just a statement that I wanted to have up there because it's quite important. The other statement, another summary statement for this section, was that beyond this, so beyond screening for mental health problems, substance use problems, and related risk, critical context such as family history, social network, early trauma, psychiatric comorbidities, physical health, housing situation, employment, and resilience are all important to explore in a conducive therapeutic setting. So I'll leave those up there for a sec for you to read. But we will obviously come back to these if you have any questions or you want to discuss these specific statements or anything related to this domain later in the discussion. to move forward to the next domain. So this domain was, the goal of this domain was to determine target populations, and was to identify the specific needs for intervention among the target populations. And a summary statement is the following. So it is recommended that specific preventative and therapeutic needs be addressed in the treatment trajectory of vulnerable target populations. And this includes marginalized youth living in marginalized environments, youth with concurrent disorders, youth with complex familial social environments, youth of childbearing age. And so for each of these target populations, specific statements were made. So for instance, for youth with parents who suffer from substance use disorder, special attention should be paid to the youth's experiences and their relationships with their family members. Another summary statement, which was important for this, is that it is important that any service that are specific should be integrated into youth-tailored services and to any other specific services. For instance, one of the statements was that for young females of using substances who are expectant mothers, they should be provided with support that are specifically addressing their needs, including prenatal or postnatal care services, health education and counseling services, as well as family planning services. Similarly, youth with concurrent conditions be specifically engaged with multidisciplinary teams, specializes in dual diagnosis among youth. So that was a summary of this second of 5 sections of domains, and really addressing what the target populations are among the more general population of youth. The third domain, and the aim of this domain was to define intervention goals. So an important, really important statement for this domain was that the principal objectives in treatment are risk reduction and mortality reduction, as well as increasing resilience and positive development. So that should be, and that was the consensus that was reached among experts, that the objective of treatment in youth with substance use disorder or high risk substance use is a reduction of the risk of using substances, and obviously a reduction of the mortality, but also increasing their resilience and their positive development. Substance use treatment should be goal-oriented, tailored to each individual, and provided in partnership with youth and others collaborating in their care. So this is also a really important one, specifically mentioning the goal orientation and tailored to each individual. And finally, another summary for this domain was that it is important that this goal orientation, tailoring the treatment program to each individual, happens as early as possible and be based on skills training and accessible resources. So I'm going to go over the last 2 domains right now, and then we can open the floor to discussion. So the fourth domain here is the aim of this domain was to explore the experiences with evidence-based intervention strategies in the current system of care. And the first statement or summary statement of what was discussed is that it is recommended that all evidence-based interventions be made available to youth, including targeted prevention, early intervention, and especially pharmacotherapy as first-line treatment of opiate and benzodiazepine dependence. That's a really important one. So experts all agreed that specifically OAT, so pharmacotherapy, be used as a first-line treatment for opiate use disorder, which is not the case right now, at least not in North America. Another really important statement for this on evidence-based interventions is family involvement, which is an important resource for youth. So family involvement is often recommended and can happen in a lot of different ways, considering the specific experiences of the individual youth, but limited or no parental involvement should not be a barrier to treatment for youth. And that's really, really important. So it shouldn't be a barrier. So if youth don't want their parents involved, or for some reason don't have any parental caregivers, then it shouldn't be a barrier to their treatment, and they should be allowed to receive the targeted prevention, early intervention, and treatment that correspond to their needs. And the fifth domain is to identify appropriate treatment settings and expertise. And this has to do with the responsibility and coordination of various medical disciplines involved. So one summary statement here is that it is recommended that all treatment settings and professional teams be empowered through specialty appropriate education and training for proper referral or management of high-risk substance use among youth. So it's not only a question of knowing where to refer people to, but it's that they should feel empowered to work with this kind of population. And this is not only a specialty, this should be among all professionals and all treatment settings. Another important summary here statement is that peer support and case managers are quintessential to all treatment settings, and seamless transition and handoff between treatment settings are really important. So say a youth is going from a or young adult is going from a youth treatment facility to an adult treatment facility, there should be perfect seamless transitioning and handoff between those two, and the youth shouldn't feel any disconnect between the two. So I think I've rambled on quite a bit about what the Delphi study was, what the experts who were involved in the panel were, and what the consensus statements were. I'm just going to talk about one more thing, and this is very interesting. It's what was of contention among the experts, and then we can have a discussion later for any questions. But so though, as I mentioned before, consensus was achieved for the screening of all mental health problems and substance use problems, but there was a concern among experts around the feasibility of screening all youth, due to a risk of labeling, stigmatizing, and potentially inappropriately pathologizing youth, but also because of the just general feasibility of screening all youth in terms of capacity to do so. From a feasibility standpoint, there are already many illnesses already screened for in primary healthcare. So the experts on this, for this particular topic, agreed that there should be universal screening, and also mentioned that a broader evaluation of the healthcare system as a whole is actually needed if screening for mental health problems and substance use disorders, which are the leading cause of disability in children and youth, is unfeasible. And then the only statement that really did not reach consensus was involuntary admission, which is a complex ethical issue in youth and still highly contentious in adults. So although most experts did agree that involuntary admission could be considered as part of a comprehensive treatment approach, most experts also drew attention to the potential significant consequence it could have on the trust and engagement of patients. So the worry is that youth who are hospitalized involuntarily report more distrust, including perceiving inpatient treatment to be more punitive than therapeutic. And so for that reason, the panel didn't come to a consensus on an appropriate statement of this much weight and magnitude without first gathering more scientific evidence. So the discussion here should be on how to intervene youth early and engage the patients throughout by meeting their needs. So given what I've spoken about, I've been rambling on for quite some time now. I want to leave room for any questions or discussions. Maybe we can take a look at the chat and see if anything has come up. So I'll open the floor to everyone. So I'll stop sharing my screen and we can all start discussing. Martha, was there anything, I don't know if you've been following the chat or if there's anything to first we can bring up first, or if we want to address.
Yeah, I think thanks, John. You did a really nice job summarizing the consensus and sort of describing the study, which was certainly a time-intensive process for you, and I hope will be a really helpful document for others that work with youth with substance use and use disorders. There's a couple of questions. I. Morris asked for clarification from you, Jean, about the classification of leading causes of death in youth. And her question was around, was suicide the second cause of death? And is that classified as an intentional death or otherwise?
Yeah, so the way that the BC government and Canadian government and the US have that data available is that it's listed as, so unintentional injuries are separate from suicide. So the assumption would be that it is intentional. Suicide would be intentional and is not in the unintentional category. That answers the question. Unfortunately, I don't really give any more information about that on the websites that I found.
And then a couple of comments sort of agreeing with some of the statements that you make, that sort of pathologizing any kind of diagnosis may not be helpful. And just a reminder to those of us that are on the call that trauma, an experience of trauma, does not equate to a diagnosis, and that sometimes there can be some value in making a diagnosis in order to help with access to income or additional types of supports.
Mm-hmm. So I also saw here it also said that CBT is the gold standard for therapy counseling, but most youth don't do well with this therapy, especially if trauma respondents are difficult for them. So, youth leave a counseling session becoming very dysregulated, angry because they weren't really understood. So I don't know if you can touch on that, or how to best have a youth feel like they were understood, or deal with that trauma-informed care.
Yeah, I think it really depends on what it is that we're seeing an adolescent in the office for. So I may not entirely agree with that statement that CBT is the gold standard for therapy or counseling. I think if you have an adolescent that is presenting to your office with an isolated depression or anxiety, then CBT may be sort of the gold standard or first line therapy. However, for patients that have sort of more complexity around that, substance use, a history of trauma, other adverse childhood experiences, then I think that cognitive behavioral therapy may not be the appropriate treatment response. And I think we need to spend some time sort of getting to know the patient that is in front of us, what their goals and priorities are, and be comfortable using a little bit more of an eclectic treatment approach to first sort of meet them where they are at, ensure that their basic needs are met. It's very difficult for an adolescent to be talking with me about their depression or anxiety or how many hours of sleep they're getting a night if they don't have a place to sleep at night. And so that's where sometimes engaging others, especially case managers or other social workers, to think about what is the priority for the adolescent can be incredibly important, and one of the mechanisms to build a relationship with that adolescent, to show them that their priorities are your priorities, and to develop any kind of therapeutic alliance. And I see there's a comment that relationship and rapport is the number one, and I wholly agree with this. This is what the evidence supports for any type of psychotherapy, that the single most important factor is the therapeutic relationship that you can build with the patient. And that's going to be true for cognitive behavioral therapy, for psychodynamic psychotherapy, for dialectical behavioral therapy, or others. And I just almost always, in any type of clinical environment I'm in, I'm almost always using a motivational interviewing framework. I think it is very adolescent-centered. It is very in keeping with their developmental profile, and really is a way to get to know the patient that you're working with in a not pathologizing, very patient-centered way.
Mm-hmm. There was also a question on the Whova. I was just curious about inclusion and exclusion criteria for experts in the area. So yeah, I didn't really talk about that much, because unfortunately for substance disorder in youth, there is no international collaboration for it. And so we were essentially starting afresh. There is a collaboration for ADHD and substance use, which is something that has been published on for a consensus statement, but nothing for high-risk substance use. So we were basically connecting with our network and through purposeful sampling. So connecting with other clinicians in the area, asking them if they know of any experts in their country, in their respective country, to being involved in this panel. So no real inclusion or exclusion criteria. It was mostly purposeful sampling, unfortunately, because there is no international network or collaboration that is already in place for such a thing. That was just to answer one of the questions. I want to address that first. There's also a comment, my experience in working with youth that have trouble with regulating emotions is using DBT over CBT due to having the distress tolerance and emotional regulation as part of their DBT. What has been your experiences? So Dr. Iggy, this is for you.
Yeah, so my leaning is that I favor DBT over CBT. I sort of see them as subsets of one another, but I think the skills that we can learn in dialectical behavioral therapy around emotional identification, around distress tolerance, can be incredibly helpful skills for any teen to be learning, especially teens in particular that may have difficulty with emotional impulsivity or emotional dysregulation. I tend to be more of a lumper of psychotherapies than I am really a splitter. So I sort of think about using any of the sort of tools or skills, depending on who it is that's sitting in front of me and what their goals and priorities are. And I go back to sort of one of those statements that I made earlier, that I think we sort of need to think about Maslow's hierarchy of needs. We need to start with what are the basic foundational principles of safety and having your needs met before thinking about learning to respond to a traumatic situation, because a lot of these what we may call maladaptive tools or skills may serve a purpose in certain environments. And so we need to ensure that we're not leaving adolescents or anybody that we're working with without any tools or skills to manage a potential situation. So thinking about safety, thinking about housing, thinking about access to food, and then thinking about, once those are satisfied or at least being engaged, being able to then to start work on emotional regulation.
I definitely should have mentioned this at the start, but if you have any questions, and feel free to unmute yourself or turn on your camera. It would resemble much more of a more natural workshop or a more natural discussion. And I think that we would, like Dr. Iggy and I would both prefer that, I think. So if you have any questions and don't really want to type it, please don't hesitate to unmute yourself and to ask the question. So there was one on.
And I will add to that,
yeah.
John, John and I are not the only experts in the room. We recognize that everybody that is on the call today has a lot of expertise working with youth and youth with concurrent disorders. So we really welcome your thoughts, your input to any of the questions that are coming up, how you've approached these situations, and additional conversation.
Yeah, no, well said. There's also just one question that I want to quickly answer is the Delphi currently published? So it's actually currently submitted. So we're in the process of having it accepted and published. So that should be coming out relatively soon. So that answers that. So we just wrapped up, we just finished the manuscript like a month ago. So it's been just in the formatting phase and the submission phase up until now. So just to answer that question.
I just have a question. I missed what you said regarding ADHD and substance use, regarding a statement. What was the statement?
So I will post it on the chat. So there is a published international consensus statement already for ADHD and substance use disorder for youth. And that was really is an important paper that we used as well for this own project as a baseline or as something that is done similarly. And so so what I was mentioning before is that there's an international collaboration that is in place that was used to develop that consensus. So I'll share the paper with you, with the chat actually. And if you want to read up on it, you can, but I was just mentioning it as a side note, as something that we use to build upon for our own paper. Does that answer your question?
Yeah, thank you so much. And so I know that it's a paper, but I'm hoping they would say that you need to treat the ADHD in order to be able to, you need to do both. But I know a lot of times people are afraid to treat ADHD because it's a stimulant, even though stimulants have, so much evidence to prove it to be, safe. And I get their concerns regarding heart risks and stuff like when you are using substances. But I'm just hoping that they say treat concurrently both the substance use and ADHD.
Yeah, Jennifer. Yeah, definitely. I like it. Definitely. So they came up with a bunch of statements that also, and it was really useful because they came up with statements and also identified where there was no research in the area. So it's a very, very helpful paper, and I'll plug it into the chat as soon as I get a minute to look it up. I think that it's something that you'd enjoy to read, Jennifer.
Thank you.
No problem.
John, there's a question in the chat that asks about sort of future research directions and whether there's been any thought about including other people of the community as experts.
Oh, definitely. Yeah, no, that's a really, really good point, right? Because it's not just the physicians, it's everyone related to the youth, everyone in their network that can help with them. And this involves, especially any adults that the youth look up to, or like it could be sports coaches, it can be teachers, it can be anyone really related to it, as well as harm reduction services and things like that. So Definitely, it's a good question, and it's a good topic of discussion for like what is the next step. So now that we have this consensus among experts in the field who are physicians and researchers, what can we do now? And I think a good next step would be education and emphasis on workplace culture. So continuing and specializing not only clinicians, so yes, clinicians who aren't specialized in addiction, so all clinicians, but also promoting awareness in the institution, and also creating maybe more specialized statements or consensuses or guidelines for the particular services that are needed. Is there anything else to add, Martha, to that, or Dr. Iggy? Sorry. No. Okay.
I think that, Jean, this is the second time that Jean and I are presenting the research that he has put together around developing these consensus statements. The first was in an overdose conference in January, and one of the comments that came out of that, and I think is very consistent with this question, is sort of looking to the community and thinking about how do we best partner with community providers, and not just physicians, right? Really the people that are on the ground doing the work, the therapists, the social workers, the case managers, MCFD, and everybody, and how do we work on getting everybody actively involved? And I think if folks on the call have a great idea or great suggestions, I think we're very keen to hear them. I'm very hopeful that that's the future direction of where we're going. We know that sort of these silos of treatment really are ineffective, and being able to have a supportive community and a supportive team around an adolescent or a youth that can help support them in multiple capacities is going to be the absolute priority.
There's one, yeah, go ahead.
I was just going to comment, there's a couple of statements around sort of ADHD and diagnosis or misdiagnosis that I think is worth addressing. So ADHD and substance use historically has, and especially the overlap, has been a bit of a controversial topic. We know that there are huge rates of underdiagnosis, and then there's also evidence that suggests that ADHD in the general child population may be overdiagnosed in certain populations. And there's a really important comment made here, thinking about some of the overlapping symptoms of somebody that has exposure to early trauma or high number of adverse childhood experiences, and how this may present looking similarly to ADHD, but may not be commensurate with an ADHD diagnosis. And I think that that's something that's incredibly important to tease apart. We know that ADHD has tremendous heritability. We know that untreated ADHD, I sometimes get on a bit of a soapbox about this with my non-child psychiatry colleagues, that there can be substantial executive functioning impairment for people with ADHD. This is not a luxury or designer diagnosis. This really can have a lot of functional impairment, in particular impact sort of risk-taking, early exposure to substances, and can be associated with very high rates of increased use of substances and rates of use disorders. So I think it's incredibly important to screen for accurately, and then also to think about treatment. And I see that Jean has actually put up the article that's the consensus statement for looking for ADHD in youth with substance use disorder.
Absolutely, yeah. So also comment on the Hua says, how can we better resource youth supports and programs with harm reduction? So less about if, but when young people use. I'm struggling with youth services getting on board despite no duty to report for youth accessing harm reduction or naloxone. So much of the discussion, I think, for programs with regards to harm reduction services start early, and preventative and early interventions. In Australia and in Germany, especially, they have school-based curriculum programs that really help educate and provide resources to youth in case there is, if they want to learn about the risks involved, and it can really be a really important resource for them. So that should be definitely the first place to go. But then we also had a discussion with the experts with regards to consensus as to naloxone and when that should be dispensed. And general should be as much as possible to the family, to the surroundings of the youth, so that it is there and they're aware. And it should be a discussion that is had with the youth openly about it. So it should be a discussion, and they should know, everyone around it surrounding you should know how to use it, where to get it, in case they need it. It shouldn't be something that is not really discussed. Yeah. Anything to add, Martha? No, okay. One of the questions was safer supply discussed for youth? Martha, do you want to tackle this one? Safe supply?
Yeah, so safer supply in and of itself wasn't specifically discussed. It did fall, I would suggest that it falls under consideration of other treatment options that are available to adults. You know, we did discuss sort of like safe injection or safe consumption sites, needle exchange, family planning, that all of these options should be made available to adolescents. Safe supply and pandemic withdrawal management is a very new concept at this point in time that has really come out as a result of the COVID-19 pandemic. It, as a treatment option in and of itself, is not as evidence-based as many other treatment options, such as opioid agonist therapy for adults. And the practice really at this point in time is ahead of the data or the evidence base. I can tell you that empirically or anecdotally, I have seen adolescents who are on safe supply have had it prescribed through the Foundry and other clinical treatment settings here in BC. I'm curious if there's anybody else on the call from, I know that some folks said that they were from other parts of the country, some folks from Alberta, where my understanding is that the Safe Supply Initiative has not had the same level of uptake. And perhaps, I think anecdotally, I've also heard that sort of outside of the Lower Mainland, directly in Vancouver, there's less uptake of safe supply or pandemic withdrawal management the further we move away from Vancouver, even in BC.
Yeah. So again, if anyone has any questions, please unmute yourself or put it in the chat. So for now, there's nothing. Martha, I was wondering if we could maybe discuss pharmacotherapy and like the non-use of it right now in the healthcare system and how to possibly address that. So like the consensus statement is a way of really saying that experts in this field have agreed that this is the front line, and it's not necessarily right now, maybe because of stigma towards providing youth with pharmacotherapy, like a preference or a personal belief towards abstinence-based treatment first. So trying abstinence, and then if it doesn't work, then we provide them with pharmacotherapy. And so I was wondering if you can just kind of discuss what the options were and how that has worked clinically.
Yeah, so I think that as somebody who has worked in the US and now in Canada, certainly the treatment philosophies and paradigms can be very different. And I'm lumping in two very different countries which have very different leanings depending on where you're in. So in the US, I was bi-coastal, and I have colleagues in sort of more central portions of the US where treatment philosophies are very different. And that's going to be true wherever you happen to be. I think that there is progressively more discussion about adolescent substance use and substance use disorders in the last number of years than there has been in the past. If we actually look at the evidence base and the amount of publishing that has happened in this topic in the last 5 years, there's been a dramatic increase, which I think is very promising. So first, experienced providers are learning a little bit more about this through the evidence base. There's younger generations of folks in the healthcare system, and I mean that broadly, are learning about the impact of adolescent substance use and are learning more about what treatment options exist. There's also been a lot of efforts by national organizations such as the American Academy of Pediatrics to actually help empower primary care doctors, pediatricians, and other child and adolescent focusing providers to increase their awareness of the topic and also increase comfort in accessing opioid agonist therapy. I think the biggest reason that there's been low uptake is one, if we're not screening and we're not directly working on identifying this as a challenge for somebody, it can be very easy to miss adolescent substance use, because adolescents may not have the same constellation of symptoms or impact that an adult may have. So if we're not routinely looking for it, we're missing it. And then there's a lack of experience, and that leads to provider discomfort. And so I think by continuing these conversations, having groups of everybody like this involved in the conversation, I think that's really going to be important to move treatment forward.
Awesome. Yeah, no, well said, Martha. Thank you for addressing that. Another comment is just parents also don't all want to speak about their own parenting or trauma, and so many aspects can be missing diagnosing children as well. And that touches on involving the family, and so when to involve the family and when to not. And I think it's important, even in dysfunctional families or in the case of divorce, like parents or caretakers do remain a critical resource for recovery. But as I mentioned before, like limited or no parental involvement should not be a barrier. So it could sometimes be counterintuitive. This was something that was discussed among the experts, like when is family involvement productive, when is it counterproductive? So if, for example, when there's abusive relationships, violence, estrangement. So in that position, it's important for youth protection to be prioritized. But for the majority, and it should continue to be encouraged to have family involved with like education, enhancing trust, relieving concerns, to have interventional strategies that work with the parents and caretakers and youth in parallel, and it really until they agree to have common sessions. That's family involvement is important.
And I will add, if you're able to frame for the family or the parents why you may be asking some of the questions that you are, invariably parents are joining you in the office because they want the very best for their kids. They may disagree with you on what the very best means or what the roadmap for that is, but without actually discussing and providing a little bit of an understanding of why you may be asking some quite intimate questions about their own previous history or past, that may be something that they don't routinely understand. So I think that we sometimes may do a disservice to kids, their families, and other providers by not sort of contextualizing the information that we are the information that we are requesting as part of our initial assessment or ongoing assessments.
Yeah. So we're getting towards the end already, which is crazy. So it happened so fast. And I just wanted to maybe have one or two slides to bring things together. And I was just going to share my screen. If there are other comments or questions, like please voice them in the chat. But for now, I was just going to present like the kind of takeaways. Do you all see us, Martha? Do you see the slide main takeaways? Yeah. Okay. Awesome. So as I said, so aside from the individual statements that we discussed, like what are the main takeaways from this international group of experts? Well, I think that a good reflection of it is that if we want to reduce high-risk substance use prevalence and overdose among young patients, we need to start using evidence-informed practices. And this includes staying away from subjective or personal beliefs. And we need a continuum of care from lifestyle mentoring and targeted prevention to early crisis response. So a clinical trajectory addressing not only their physical, but their developmental and mental challenges that need to be established. And the services and resources must be tailored to their own therapeutic needs. I think that that's really important, and that family is a major resource, as I've mentioned already, and should not be a barrier to their care. I think another important part, especially regarding in the case of overdose or serious life-threatening events like binge drinking or suicide attempts, there needs to be a youth crisis response system that has to be established. So every youth waking up in an emergency room, maybe after a binge drinking episode or an overdose, should get the best possible care immediately. So that number that I brought up, the 2% receiving pharmacotherapy 30 days after an overdose, that is ridiculous. So this includes like a diverse range of effective and available treatment options that should be offered. They don't necessarily have to take up with it, but they have to be offered at least. So, counseling, case management, family involvement, pharmacotherapy. And there also has to be just more research in general. And so clinical research and innovation for new settings of care as part of the healthcare system development would help with the effective prevention, treatment, and management of high-risk substance use among youth. And a couple of just final words, so calls to action that I think these consensus statements bring together is that these alone have little to no merit without any implementation. So an important first step would be to further understand country-specific adaptations that may be different because of culture, legislation, and philosophies of care. And these need to be integrated into policies which clinicians, as well as other healthcare providers, should be incentivized to execute. And this touches on education and emphasis on training and of addiction and psychiatric care. And then finally, as I mentioned before, the international platform. So these best practices have to be shared amongst providers around the world. So if something is working in a different country or a different part of the world, there should be a collaboration or a discussion onto if that should be implemented in other places. So I think that a general conclusion is that the take-home message would be that we're failing to provide good care to youth. So we don't really have a system in place for it, and that the system is in disarray, and that this lack of academic effort and dysfunctional treatment system is leading to a lot of overdoses, and not only overdoses, but also other problems and other risks related to their substance use. So the consensus process that we just went over is an important and necessary first step in addressing reform and systematic development. But next steps should include and have to include design and implementation of solutions according to the regional context and of each healthcare system. So, and without this change, right, rising fatalities, especially through overdose, are really unavoidable. So I just want to leave you with that. It's 12:56. So if there are any other last minute comments or questions, please feel free to put them in the chat. If not, we will wish you a wonderful conference. And Martha, if you had any last words that you want to maybe give, I'll give you the floor right now. If not, then we're all good.
I just wanted to thank everybody for taking the time to join us today. It's really heartening to have so many folks prioritizing working with youth and joining us for this hour. And I also just wanted to make a second comment. Lauren from Foundry in Victoria has offered to share her or their experiences, I should say, for youth accessing safe supply. There is a chat function in the platform that the conference is on that I think it can be really worth sharing experiences, sharing cases, and sort of continuing the conversation. And hopefully we'll continue to work together in the future.
Yeah, absolutely. Are you able to send out the article to attendees when it's published? Yes, we can absolutely do that. We'll share it to our newsletter and to our list of attendees. Absolutely. Thank you for pointing that out, Kathleen. Okay, wonderful. So everyone, thank you. I hope you have a fantastic rest of conference. I think that now for those in BC, it might be lunchtime. If not, I wish you the very best of day, and then we'll see you around. Thank you.
Thank you so much.
Thanks, everyone.
Thank you.
Thank you, Ms. Vernon. You have your mic. Your mic is working now.
Oh, good. Thank you.
It works.
I didn't know if it did.
From the last conference.
Thank you. Oh, that's great.
Okay, I'm going to shut this Zoom down. Martha, thank you so much again.
No, John, you did such a great job presenting all of that.
Hey, George. Hey, George. And yeah, I'll see you both actually tomorrow, VGH.
Sounds good.
All right, bye.
Bye, John. Enjoy the rest of the conference. Good luck with the rest of your talks, eh?
Thanks. Bye.